Also, I'd like to thank my friends Sella Pandian and Mohan and Dr. Gnathan and Santanam for giving this opportunity to be part of this wonderful meeting. I think I must first compliment the organizers for giving so much time, both for presentation as well as for discussion. I think that always goes. Sometimes you have a good topic or a good speaker, and everything gets over in 15 minutes, and hardly there is any time for discussion. I think from that perspective, the agenda needs to be complimented, and congratulations to the organizers for choosing few topics and accommodating them in a manner which will be satisfying both to the presenter as well as to the audience. So in this topic of the guidelines of diabetes, as Chairperson Dr. Sella pointed out, the guidelines are there, it is up to us to react to it. So what I thought I will do in the next maybe 35-40 minutes is the first 20 minutes, I will dwell upon the rationale behind the various guidelines. I mean, what was the message which enabled the organizations across the world to formulate these guidelines? How did they go about this job? If you say HbA1c 7, why? Early in the stages of diabetes, good control, why? So they had the inputs from various random control trials as well as observational analysis as well as the expert opinion and the experience that all of us share with, which resulted in the formulation of the various guidelines. And then maybe see some of these guidelines in rapid succession, which will be relevant in the day-to-day practice of diabetology. So the goal is ultimately the same. What are the need for guidelines? In my opinion, few necessities for the guidelines have been highlighted in this particular slide. That is, in the context of diabetes, which is growing in epidemic proportions. And then all of us are aware of the suboptimal management in the sense that we always talk about in a given population, how many people have achieved the target HbA1c 7%, 13%, 21%. So we are aware of the entity of the suboptimal treatment. Can guidelines narrow down what is being discussed in the literature, what is being optimal, and then when it is being practiced, can these guidelines narrow them? Certainly it will. In fact, these guidelines will enable a semblance of uniformity in the approach of various clinicians across the world, so that some amount of commonness will be there with the approach to the diabetic patients, which goes long good. And of course, in the process, they will also be aware of positioning of the molecules, how far you should go, what you should not do, etc., etc. Now, as I told earlier, before we go into the guidelines, how did these guidelines emanate? Right from the time the necessity to treat diabetes was appreciated to prevent the vascular complications, people have always been asked, how far should I go? Now, the logical way of treating any disease for that matter is to restore normalcy. Hyperglycemia is high blood sugar level. Try to reproduce euglycemia. You and I know that it's virtually impossible to bring down euglycemia in the diabetic population. So, when you know that hyperglycemia produces problems, when you know that euglycemia cannot be achieved, the best way is to find out some evidences wherein bringing down the blood sugar level to a target has been associated with beneficial effects. And the first step to do that was the DCCT in the type 1 diabetic population. The Pirarad was one of the earliest persons to document an association of hyperglycemia with vascular complications. The clinical wisdom in everybody suggested that you should bring down the blood sugar level, but how much and how long? The first evidence in the literature was given by the DCCT, wherein they said, if you're going to bring down the blood sugar level in type 1 diabetic patients, whatever be the initial baseline HbA1c to around 7, then it is with benefits. So this was the first message which made all the guidelines formulate the various steps that they have been doing so over the years. So subsequently, type 2 diabetic subjects have been studied, and then more or less the same results have been replicated. So the first message which served as a signal to the people who matter for the guidelines are treat diabetics to a target, and this target probably should be around 7%, which is probably quite obtainable both in the trial setting as well as in the clinical setting. And this is associated with some meaningful favorable effect on the impact of the vascular complications for which we are treating our diabetic subjects for. And having said that, the various guidelines are aware of the fact that once you are going to treat a diabetic subject, be it type 1 or type 2 diabetic subject, be it oral agents or with insulin, there is always an inherent risk of inducing hypoglycemia. Iatrogenic hypoglycemia is an accepted side effect. Moreover, as you will see here, when the HbA1c goes up, the complications go up. And with treatment, when the HbA1c tends to be normalized, as you will see here, certainly the risk of hypoglycemia is always there. So this was second message to the issue of guidelines, in the sense that whenever you recommend something, a treatment modality, you harp on the importance of bringing down the blood sugar level. At the same time, be cognizant of the fact that if this particular modality is going to be associated with the risk of hypoglycemia, then if there is an alternate modality which is time-tested and safe and effective, maybe that could be preferred. So this was a soft message that has also emerged in the formulation of guidelines. A third important message that has emanated as a follow-up of the DCCT study is the EDIC follow-up. We are all aware of that whenever you do a drug trial, as the patients are on a drug trial, when you achieve a target, like for example the intensive arm of DCCT, it was not surprising that people who were in the intensive arm, they did well with respect to the vascular complications. Good reduction of the HbA1c resulted in meaningful effect in the various endpoints, the vascular, microvascular endpoints. But what was more important was, after the study got over, both the original patients of the intensive as well as the conventional arm, they went back to the practitioners. Subjects in the intensive arm maybe lost some amount of motivation to pursue a good glycemic control, and persons in the conventional arm, they were better motivated, so their HbA1c was more or less the same after the trial was over. But still, the beneficial effect which accrued out of a good glycemic control during the trial persisted after the end of the trial, even though the glycemic control was not good. I think this was a very, very important message for the guidelines subsequently which emanated, wherein they harp on early aggressive glycemic control. So the first message was diabetic subjects have to be treated to a target, and achieving this target is always fraught with the risk of hypoglycemia, and good early glycemic control pays dividends in the long run. You and I know that after say 10 years or 15 years of diabetes, be it is type 1 or type 2, it's slightly difficult to maintain a good degree of glycemic control. But had this patient been treated to a target very early in the stages of the disease, even subsequently the control has not been that good, still the beneficial effect persists. So good aggressive glycemic control in type 1 diabetic subjects, and so in type 2 diabetic subjects helps. And the fourth message that accrued out of all these landmark trials was, whatever be the mode of therapy, the glycemic control escapes in the natural history of type 2 diabetic subjects. Be it glibenclamide, metformin, chlorpropamide, or any mode of therapy, including insulin, unless it is not titrated to a target. And in the UKPDS, like the DCCT, the initial benefits which was not very apparent, especially from the macrovascular point of view, because of the legacy effect or because of the good glycemic control being instituted in the early stages of the disease, got translated into vascular benefits down the line. And some of these slides I've thought I'll re-emphasize time and again, just to impress upon you that good glycemic control in the early stages of the disease, as you will see here, the beneficial effect which was there in the intensive arm, even after the trial was over, persisted almost for about 15 to 80 years after the trial was over. Coming back to the context of the type 2 diabetic subjects, extrapolation of some of the data from the UKPDS of the type 2 diabetic subjects not only told us that it's virtually difficult to maintain in monotherapy type 2 diabetic subjects in good control for a longer period of time, but also taught us one important aspect of the pathophysiology of type 2 diabetic subjects. What was that? Traditionally, we have always been taught that type 2 diabetic subjects is an insulin resistant state. But if you look back, not all insulin resistant subjects develop diabetes. Most obese subjects are insulin resistant, and not all of them develop diabetes mellitus. So, type 2 diabetes mellitus is an insulin resistant state, but what precipitates diabetes is, besides the insulin resistance, which is hallmark of type 2 DM, the insulin secretory defect or the pancreatic beta cell secretory defect. So as you will see here, by the time the diagnosis of diabetes mellitus is made, almost 50% of the beta cells function is lost. And once the diagnosis is made, subsequently every year, maybe about 4 to 5% of the beta cells are lost. What it means is, number one, for type 2 diabetes mellitus to be manifest, along with insulin resistance, secretory defect of the pancreatic beta cells is mandatory. So without the secretory defect, no one develops type 2 diabetes mellitus. That's number one. Number two, for you and I as clinicians, what is more important, which the guidelines have now stressed is, when you treat type 2 diabetic subjects, very early in the stages of the disease, address the secretory defect also. And if you're going to address the secretory defect, physiologically, like for example, your incretin-based therapy, then you take care of the secretory defect, which is very essential in a physiological way. Maybe you're not exhausting the beta cells. And also, you're going to probably preserve the beta cells for a longer time, because you know from the UKPD's extrapolation that the beta cells lose their capacity to react to the situation in a manner to the tune of about 5% of the functions, so on and so forth, so that maybe after about 10 or 15 years of type 2 diabetes mellitus, more or less the beta cells are bankrupt with respect to their capacity to secrete insulin, given the situation of the hyperglycemic environment of the diabetic subjects. So this is just re-emphasizing the aspects which were discussed in the previous slide, the beta cell function. So now the messages, as I told you, I thought I'll spend some time more in detail about the messages that accrued out of the various trials, which have been instrumental in all the formulation of the various guidelines. The first message was type 2 diabetic subjects have to be treated to a target, which was initially available in the type 1 diabetic population, subsequently in the type 2 diabetic population. This target probably around 7%, because most of the trials attempted to be around the vicinity of 7. And early aggressive glycemic control helps in the long-term prevention of complications, and beta cell secretory defect is present before the onset of type 2 diabetes mellitus and is progressive after the onset of diabetes mellitus. And in the treatment of diabetes subjects, not only the insulin resistance, the secretory defect also has to be taken care of. So with this information, some of the trials which have been conducted in the last decade or so, the intention, the motive was very, very clear. The expectation was very honest or on logical grounds. UKPDS recruited raw, fresh type 2 diabetic subjects drug naive, and then instituted a mode of therapy with sulfonylureas, insulin, and metformin, which was found to be beneficial if the target has been, say, around 1%, if the HbA1c reduction was to the tune of about 1%. It was wishful thinking that if type 2 diabetic subjects early in the course of the disease can be treated by a reduction of 1%, then what about type 2 diabetic subjects with longer duration of diabetes, more vascular complications, who are much more vulnerable for future complications of vascular disease, in whom, if good glycemic control is going to be beneficial, then I think this can be incorporated in the various guidelines. I think this was the motive behind the various trials. And what were these trials? We know that the ACCORD, ADVANCE, and the VADT. So unlike UKPDS, which was which recruited drug-naive, fresh type 2 diabetic subjects. These 3 trials targeted, focused, and recruited subjects with longer duration of diabetes, more than 10 years, 35 to 40% having a vascular complication, be an MI or a CVA or being subjected to a procedure like a PTCA or a CABG, highly vulnerable population. In them, thus a tight glycemic control, much more than what was achieved in the UKPDS, like 6.5 or less than that, will it be beneficial? This was the motive of a good glycemic control in these 3 studies in a huge number of population, 10,000 subjects in both ACCORD and ADVANCE, and of course about 2,000 or so in the VADT. We knew the answer. The ACCORD trial had to be terminated because there was excess mortality around 3.5 years in the intensive arm. So if you superficially look at it, then what it means is good glycemic control, tight glycemic control is not beneficial in patients who have had longer duration of disease, or if you want to be much more simplistic, you can always say it can be dangerous. It can be associated with increased mortality. Now, you have to synthesize certain amount of hypotheses based on the inputs from the various studies. UKPDS and DCCT said early in the stages of the disease, you target diabetic patients to a particular target and treat them. The vascular benefit is obvious. Now, ACCORD trial and ADVANCE trial tell you, down the line after 10 or 12 years of the disease, it is not beneficial. On the other hand, it may be even detrimental. So this is where the metabolic memory or the legacy effect comes. In UKPDS, it was presumable that patients were recruited in this very early stages of the disease. The HbA1c maybe was not that high, or even if it is high, with limited efforts, you could bring down the HbA1c. Whereas patients, for example, in the VADT, after 10 years of diabetes, the HbA1c of around 9 or 9.2, in them also you can bring down the HbA1c with a lot of efforts. Multiple therapy, with or without insulin, lot of secretagogues, insulin sensitizers, with touch of insulin, etc., bring down the HbA1c. Now, you and I as clinicians, I think will be impressed by this construct for the simple reason, in the VADT or ACCORD or ADVANCE, subjects were caught here and then in a rapid time, the HbA1c was normalized, whereas, I'm sorry, I'm not audible. Okay. Thank you. So you can take the subjects here and then bring down the HbA1c. You have normalized the HbA1c, you have brought it down to get a stiffer target, but what probably might have happened is the previous 9 or 8 years of glycemic control has been neglected, in the sense that subjects in VADT in whom the glycemic control was achieved, then there was no apparent benefit, they had been exposed to the degree of hyperglycemia in the previous 8 or 10 years before the recruitment in the VADT, so that all the tissues have been exposed to the ramifications of hyperglycemia. So the tissues have been exposed to hyperglycemia for 10 years, the endothelium has been exposed, more glucose entered the endothelial cell, the endothelial dysfunction started, it elaborated all the inflammatory molecules, it elaborated all the adhesion molecules, it resulted in so many aspects which initiated the process of atherosclerosis or the vascular dysfunction. So subsequently down the line, when you are going to institute glycemic control, it doesn't matter. The vascular benefit with respect to the macrovascular disease was not statistically significant, which subsequently became significant in spite of the fact that the glycemic control was not good enough after the trial was over. So these are all the various arrows I'm sure we are very familiar with, 1% reduction in HbA1c, and also in the the UKPDS and the post follow-up. This is the drop in the HbA1c associated vascular benefits. Yet another caveat which has emerged out of analysis of these studies and some of the observational studies is, once you say type 2 diabetes mellitus develops after 50% of the secretory defect has developed, and once you say that down the line after each year there is going to be 5% loss in the beta cell function, then it is logical to conclude that most of type 2 diabetic subjects will eventually require insulin. So when that message is there, all the people who formulated the guidelines, they were aware of the fact that the clinicians must always be advised about the possibility of incorporating early insulin therapy in the therapeutic armamentarium. That's why subsequently when you're going to see, all the guidelines always give an allowance for the basal insulin, even in the second stage when monotherapy or dual therapy fails, for the simple reason that whatever be the mode of therapy, the beta cells are going to be failure. See, previously we used to talk about an entity called secondary sulfonylurea failure, which is a misnomer. Your glibenclamide or glimepiride or glipizide is the same molecule. It is the pancreatic beta cell which fails to respond. So it is the pancreatic beta cell failure rather than the OHA failure that is responsible for lack of response to a particular reagent which has been effective maybe for about 2 or 5 or 10 years. So over a period of time the need for insulin increases. This is just to say why people have been really impressed with the various trials, especially after the DCCT when the ADA and the EASD guideline came and subsequently they got revised, is some of the randomized controlled trials. It is not just the theory alone. See how beautifully they have managed a difference in the HbA1c between the conventional intensive arm, not for 3 months, 6 months or 1 or 2 years, for about 10 years. So if at all any meaningful inferences could be had from this, that should take into consideration that subjects originally in the intensive as well as in the conventional arm had a difference in the HbA1c to the tune of 2%, so that you can say in the intensive arm, if the beneficial effect is there, it is because of the reduction to the tune of 2%, which was maintained for a period of about 10 to 12 years. So that is why the people who formulated the guidelines were impressed about studies like this. Yes, progressive decline in the beta cell function. So nowadays we adopt a more of a reactive approach rather than a proactive approach rather than a reactive approach. Previously what we used to do is start a patient on a monotherapy, after lifestyle modification, wait for some time, monotherapy, up-titrate the dose of a single agent, then add a second agent, then wait for an indefinite period before introducing insulin. By the time all the tissue damage has occurred, and it was not worthwhile pursuing good glycemic control. Now we have a more of a reactive approach, wherein early in the stages you start on combination therapy. And as I told you, a lot of messages have emanated with respect to the role of early insulin therapy, and it is prudent upon us as clinicians to think about the possibility of early insulin also, not to persist with the various OHAs when they are not going to be effective. We'll discuss about some of the clinical situations maybe in the next 10-15 minutes. The inputs from the various trials, and especially of the ACCORD and ADVANCE, the risk of hypoglycemia and the apparent lack of vascular benefits has identified certain yet another aspects as to how you approach a patient with diabetes with respect to the glycemic target. It is not all type 2 or type 1 diabetic patients should be treated to a target of 6.5 or 7. You have to individualize. How do we individualize? You take into consideration the patient's age, the duration of the diabetes mellitus, the risk of hypoglycemia that this patient can be pushed to. A patient 42 years of age, normotensive, healthy otherwise, even if his pre-lunch blood sugar is 88, don't bother at all. You can always say. What I'm trying to say is don't push him to hypoglycemia, but you can push him to a stage wherein you can expect him to handle the hypoglycemia better, and you and I as clinicians are comfortable in this patient experiencing a mild hypoglycemia because your endeavor is to achieve a good glycemic target in this individual with respect to the vascular complications. On the other hand, a 82-year-old individual, certainly this will be detrimental. So this is just to tell you how people are poles apart, even though the blood sugar level may be the same. Your approach will be different in the first patient and your approach will be different in the second patient, as exemplified here. You can have a more intensive to a less intensive approach, taking into consideration all these aspects. And now we come to the guidelines per se. So before we come to the guidelines, what are the messages that enable these people to formulate the guidelines? This is the ADA and the EASD guideline. The messages are: type 2 diabetic subjects have to be treated to a target. Type 2 diabetic subjects have to be treated very aggressively in the early stages of the disease to prevent vascular complications. Beta cell dysfunction is present at the onset of type 2 diabetes mellitus and has an inexorable disease. Type 2 diabetic subjects with longer duration of diabetes and vascular complications, if you push them to a tight glycemic control, then the risk of hypoglycemia is much more, which is not worth it at that stage of the disease. That is number one. And number two, there are some subjects who behave differently. Some of the people cannot adapt to aggressive therapy and the attendant complications. Polypharmacy is mandatory, and introduce insulin very early. Do not wait for long. So these have been the tenets, these have been the various caveats that these organizations have had with the inputs from the material that we have discussed so far, and the guidelines have emerged. The ADA and EASD guidelines says, I'm sure it's obvious, I'm sure many of us are familiar with this, all type 2 diabetic subjects have to be treated with lifestyle and metformin right from day one. Because, yes, metformin addresses insulin resistance. Insulin resistance is mandatory or pathognomonic of type 2 diabetes mellitus. Previously, the guidelines used to say that you start on lifestyle only, and subsequently they incorporate metformin because metformin addresses insulin resistance. Metformin has been found to be so effective in most of the trials. So it is cheap, effective, targets insulin resistance, has extra glycemic benefits, and maybe beyond other realms of clinical medicine as well with respect to the malignancy, anti-malignancy effect, etc., etc. Previously, the guidelines used to say, wait for 6 months. Now, after the inputs from the UKPDS and the ACCARD and the legacy effect, the guidelines have been very, very practical in the sense, do not wait for 6 months. Even if it's 3 months, you do not achieve your target of HbA1c, then go to the addition of a second drug. Could be a sulfonylurea or a thiazolidinedione or a DPP4 inhibitor or a GLP-1 receptor agonist. Prior to this is in 2012, prior to this, the ADA and ESD guidelines were not too enthusiastic about recommending the usage of incretin-based therapies as the primary mode of therapy along with metformin in the initial stages. What they recommended was only sulfonylurea and glitazones because they said the incretin-based therapy was not time-tested, recently introduced in the market, they are expensive. For them to be recommended for the global population, probably they have not tested the time of evidence with respect to the safety as well as the efficacy and the affordability and the durability. But subsequently in 2012, having realized that beta cell function is very effective and having the inputs from the DPP4 inhibitors and other molecules which have been in use almost for about a decade across the country, across the world, or probably less than that, about 6 to 8 years, the 2012 places the DPP4 inhibitors as well as the GLP-1 receptor agonist exenatide and the liraglutide on par with, so that you clinicians have an option. We clinicians have an option. I'm sorry to say that. We clinicians have an option. If you have an obese diabetic subject with HbA1c of 7.7, 7.8, yeah, combine liraglutide with metformin, combine exenatide with metformin, you can bring down the HbA1c to around 6.1, 6.2. You address the insulin resistance, and if you are lucky enough, you can lose about 12 to 15 kgs an obese individual who is weighing about 102 kgs. And this is going to probably improve not only his insulin resistance and the metabolic parameters, in the long run, his obstructive sleep apnea, the osteoarthritis, the obesity-related other problems are going to be taken care of. So the guidelines have been much more broad-minded in the present-day context of approaching a diabetic patient. So they have included a lot of molecules, sulfonylureas, glitazones, as well as your DP4 inhibitors, as well as GLP-1 receptor agonists. The prior recommendations of ADA as well as the EASD was harping on monotherapy with metformin. Now, the AACE and the AC were the first people to say, yes, metformin is the drug of choice for all type 2 diabetic patients. But you and I know that maybe about 5% or less than that or even 10% of our diabetic patients cannot tolerate even a small dose of metformin. Metformin 250 milligram, half TDS, is not able to tolerate. What do? Don't push him with metformin. You have the option of other molecules as monotherapy in such of those metformin intolerant patients, which is a very, very small proportion. Number one. Number two, which is very, very important. You have a patient walking to your clinic, drug-naive patient, symptomatic or asymptomatic, with HbA1c of 8.3. You're going to introduce metformin, and you know that metformin alone is not going to normalize, it's not enable you to reach the HbA1c target of 6.5 or 7 as monotherapy. So, if your initial HbA1c is very high, start on combination therapy initially. This is a very, very clear message which has been emphasized in the last 3 or 4 years to the clinicians, because quite often you are not very sure in what type of patients you start on combination therapy, in what type of patients you start on monotherapy. All the anti-diabetic molecules that we have in our therapeutic armamentarium, excepting insulin, do not have the capacity to improve the HbA1c more than 1 or 1.5%. So, if your deficit, if your target HbA1c is 6.5 or 7, and if you're looking for an improvement in HbA1c to the tune of more than 1 or 1.5%, then combination therapy should be the initial prescription. On the other hand, if you have a patient with HbA1c 7.3, you want to achieve about 6.5, certainly metformin monotherapy can be continued till such time he escapes control, mandating the introduction of a second agent, which will be a DPP-4 inhibitor or a sulfonylurea. If the initial HbA1c is very high, or if the patient is highly symptomatic, then always a clause is there. You always start with insulin, because you have to eliminate the glucotoxicity. When the glucotoxicity is there, no molecule is going to be effective. So bring down the glucotoxicity, insulinize the patient. After a few months, withdraw the insulin, and then they will be candidates for OHA therapy. So this guideline takes into consideration the necessity to institute good glycemic control, target the insulin resistance, correct the secretory defects so that they document about the usage of a combination therapy very early in the stage of the disease. And lastly, a patient who is highly symptomatic, weight loss, and the HbA1c is very high, do not hesitate to start on insulin. And as I told you earlier, even in the combination therapy, there is always an option to combine with basal insulin in the early stages of the disease, because these people formulated these guidelines are aware of the fact that beta cell secretory defect has to be reminded to the clinicians, so that this option is available to you, and you can use this option wherever you feel it is appropriate to. And again, this is the strategy for insulinizing the patient of ADA and EASD. Initially, basal insulin is OHA, and subsequently the parenteral supplements will be required as required by the patient. And as we discussed earlier, it's not worthwhile to wait for a longer period for the introduction of insulin. When do we introduce insulin? Maybe we'll discuss subsequently. And if you ask me which algorithm really changed the perception of the clinicians with respect to the managing the diabetic patients, it is the AACE and the ACE guidelines, the American Association of Clinical Endocrinologists and the American College of. So these are the people, in fact, they gave me these guidelines prior to the revised ADA and EASD, which we saw in the last slide. So here, when the HbA1c is less than 7.5, monotherapy, yes, metformin is the drug of choice. If metformin cannot be tolerated, you can have. So these were the first people to say that in patients in whom a small dose of metformin cannot be tolerated, in whom metformin cannot be given, don't keep quiet. Don't send them off with lifestyle. Suggest other modes of therapy. It could be your alpha-glucosidase inhibitors or a DP4 inhibitors or a glutathione or even a GLP-1 receptor agonist as a monotherapy. So the necessity to reduce the blood sugar level, even at this stage when the HbA1c of 7.5 was highlighted by this organization of AACE and ACE. That is number one. And number two, if you look at the previous slide, there won't be any mention about the alpha-glucosidase inhibitors, because the ADA as well as the EASD guidelines do not take into consideration the context of the Asian population, wherein the carbohydrate content is very high, the postprandial blood sugar is very high. In fact, our postprandial contribution is much, much more in every stages of the HbA1c. Some of the studies have alluded to. Whereas here, in this guideline, the alpha glucosidase inhibitors are also there as a monotherapy. Then, these were the first people to say that when the HbA1c is more than 7.5 and less than 8.5, dual therapy, because in this category, monotherapy is not going to enable you to achieve the HbA1c target of 6.5. It is going to bring down. So these were the earlier people to say that combination therapy should be instituted when the HbA1c is more than 7.5 or 8. Now, in the combination therapy, what do you choose? Is it metformin sulfonylureas, metformin DP4 inhibitors, metformin glitazones, or metformin alpha glucosidase inhibitors? Here, you have to weigh your balance with the guideline. Guideline never says you should do it, you can do it. And how do you translate this guideline into practice? If you believe that incretin-based therapy, besides the cost, is going to do good for your diabetic patients, it is going to stimulate the beta cells in a physiological manner, it is going to preserve the beta cells in a manner so that in the long run, it is good for the patients, then after metformin, your choice should be DPP4 inhibitors with metformin. On the other hand, if you do not believe in that, or if you feel the cost effectiveness, because we treat a lot of patients. We treat patients in institutions, we treat patients in health centers, wherein economic factor needs to be given a consideration, then certainly you can use a sulfonylurea in that situation. Maybe you can choose a sulfonylurea which is less prone for hypoglycemia. You can choose the sulfonylurea in a dose which is less likely to induce hypoglycemia. On the other hand, if the fasting blood sugar is normal, only the postprandial is slightly high, even an alpha glucosidase inhibitor with metformin may not be a bad option. So, the guidelines tells you what molecules have to be placed and why they need to be placed. The choice of the molecule, I think it's up to us as clinicians. It's our discretion which is going to translate into a prescription and not the guideline, as Selopontian nicely told in the beginning. It's only a guideline. And of course, in the third category, the triple therapy, or if the patient is highly symptomatic, you can always go in for insulin. And then this is a guideline for intensifying insulin. A word about insulin. I think the messages from all the guidelines and the algorithms are early insulin, but how early? I'll tell you what I do in my practice. I'm sure many of you are doing the same thing. If you have a different opinion, certainly you can take it up in the discussion. If your patient is on combination of two drugs, one is metformin or an insulin sensitizer, other is an insulin secretagogue, whether it's a sulfonylurea or a DP4 inhibitor. If the deficit in the HbA1c is more than 1 to 1.5%, never think about a third agent. For example, his HbA1c is 8.8. He is already on, say, glimepiride 4 milligram and metformin 1.5 milligrams. Do not think about introducing a DP4 inhibitor or an alpha glucosidase inhibitor. He is a candidate for basal insulin, because if you're going to introduce a gliptin, his HbA1c from 8.8 certainly is going to come to 7.9 or 7.6, but seldom enable you to achieve your target of 7, or if in the younger individual 6.5. So, in the context of the various guidelines, in the context of whatever we have discussed, early insulin or a basal insulin therapy which has been recommended by the various guidelines, how do you institute in your clinical practices? You have to individualize the patient. If the fasting or the postprandial blood sugar level, or more appropriately, his HbA1c deficit is more than 1 or 1.5, there is no place for a third molecule. Introduce insulin. For example, HbA1c 8.8, fasting is 160, PP is 270, yes, small dose of basal insulin, or fasting is 180, 190. Now, if the fasting from 180 comes to around 108, 112, and the PP is around 202, and the HbA1c is 7.4, then maybe you can add an alpha glucosidase inhibitor, because this will bring down the HbA1c by 0.5 and also enable you to achieve the... So this is how you titrate the dose of your anti-diabetic molecules, taking into consideration the messages from the guidelines, as well as incorporating whatever you want to interfere with in the given patient. So this is, I think, the best basal insulin we have today. Initially, when it was introduced, everybody said it was expensive, but the benefits accrued out of using basal insulin, especially glargine, is phenomenal. You can retain your dose of OHA and then introduce a small uptitrated dose of glargine so that for variable period, for about 2 to 3 years or even up to 5 years, you can, with a limited exposure to insulin, you can retain a reasonable degree of glycemic control, as most of these trials have found out. I would like to just tell a word about the IDF guidelines. The IDF guidelines, along with the AACE, are probably one of the guidelines wherein they want you to react if your postprandial is high. So the postprandial hyperglycemia has always been recognized as an important parameter to be addressed to in the diabetic population by the IDF, especially in the context of the Asian population, and also they in their guidelines recommend the usage of alpha glucosidase inhibitors because they selectively target the postprandial or meal-related glycemic excursions. This is the IDF guideline. As usual, not much of a difference, metformin with other modes of therapy, and then the second and third drug. As I told you earlier, the most aggressive guidelines are by the AACE and the ACE, and so, to an extent, reasonably aggressive and well-balanced information is by the ADA and the EASD, and the IDF is important for the simple reason it caters to the global perspective, taking into consideration of the Asian context of the postprandial hyperglycemia as well. And this is to complete the list, the NICE guidelines, the National Institute of Clinical Excellence in UK. Again, they also, the first is metformin monotherapy, and then you have the alternate therapies. Then you have the various other small organization guidelines as well. But in essence, the message is the same. This is the NICE guideline. Now, I think we have spent almost 30 to 40 minutes. Initially, I thought I'll do it only 30 minutes on the glycemic factor. Now, I'll just end in another 5 minutes, a word about the guidelines for the hypertension management. Prior to this year, or 2012, all of us have been asked to treat our diabetic patients to a target of BP of 130/80. And the ACCORD trial was instituted to say whether a BP of less than 140 or 120 will be beneficial. In this trial, for a period of almost about 6 to 8 years, a good systolic BP was maintained, that is in the intensive arm less than 120 or around the vicinity of 120, but there was no benefits. On the other hand, the diastolic, especially in the diabetic population, the inputs have been from the HOT study, that is hypertension optimal treatment trial, wherein in the diabetic population, a diastolic of less than 80 was beneficial. So, the hypertension target by the organization, especially by the ADA, is 140/80 for the diabetic population, because advantages of pushing the systolic BP to all the diabetic subjects beyond 140 has not been proven. Again, it was a wishful thinking that the hypertension arm of the ACCORD trial will give some meaningful information if a lower systolic BP is achieved, which was not there. What they say is, if you're going to push down the BP from 140 to 120, you have to spend a lot of money. You have to incur a lot of side effects. I'll give an example. One more extra dose of antihypertensive medication, an extra episode of hypertension or dizziness, and extra episode of hyperkalemia or whatever it is. Is it worth the risk? As on date, the answer is no. So the guideline says that systolic should be less than 140, but of course in the diabetic population, the diastolic can be 80 because as on date, the evidence by the HOT trial stands. So what I have done in the last 40 minutes, as I've understood the topic, is to discuss with you the interpretation of the guidelines. We discussed in detail. I believe that I should share with you the rationale behind the formulation of these guidelines, which was based upon most of well-conducted randomized control trials and also inputs from soft observational analysis as well as the expert guideline opinions from various people in the field of diabetology. These have resulted in the various guidelines, and the guidelines are there. It's up to us to translate these guidelines into our diabetic practice so that most of our diabetic patients reach the target very safely, incurring the least risk of hypoglycemia and weight gain, and also address to the attendant benefits of weight reduction and of course the BP control and the targeting the lipids wherever possible. Thank you.
There is a prandial hyperglycemia. The patient comes without doing HbA1c, what will you approach? The instant you start with the drugs, or ask him to do the HbA1c and proceed?
So in a diabetic patient who comes with a fasting blood sugar of 108, PP of 220, few fundamental question, I'm sure many of you would have done the same thing. If you ask him what you would have eaten that day, he comes to the clinic or to the hospital to give a blood sample, so he misses his home breakfast, walks to the next Saravana Bhavan, 3 idlis and a dosa and a pongal and some sweet. This is not the breakfast you're going to have every day. Illa sir, I'm sure all of us face this. I'm just telling you, it's very practical. Do not react to the blood sugar postprandial the way the lab value shows. Find out what he has eaten. Invariably, they eat much, much more, twice the size of breakfast, because they are away from the domestic environment. The food is very tasty. They do a lot of justice. That is number one. Number two, much more important, is the dose of antihypertensive medication is missed. Have you taken your Amaryl? Illa sir, in my hurry I didn't come, or the worst part is the lab fellow told don't take the tablet. The lab technician told me, matra saapadakodadu sir. So before reacting to a postprandial blood sugar level when it is high, find out the quantum of the carbohydrate that the patient has consumed on that particular day of testing. That is number one. And number two, whether it is with the tablet or, if these two has been satisfied, certainly you can react. You can react by introducing a small dose of alpha-glucosidase inhibitor, because with 3 idlis and his dose of OHA, if his postprandial is going to be 212, you need to treat it. You cannot anyway ask him to further cut down his diet. So I react to the postprandial blood sugar level after satisfying these two caveats.
What will be the drug, sir? Just suppose 309, fasting is 106 and the 320 or something postprandial. What will be the OH?
No, if it is going to be a first prescription, certainly I will give metformin for him also. Even though metformin conventionally addresses the insulin resistance, it is supposed to bring down the postprandial blood sugar also. Number one. Number two, that is the standard teaching, and it does something to alleviate the insulin resistance, it comes down. So the example that you have given, if it is a raw patient for the first time, then certainly you can think of metformin at that stage. Only thing is, how do you categorize him? Maybe if you go by the fasting blood sugar level alone, then it is IFG. Whereas the postprandial blood sugar doesn't enable you to make a diagnosis, makes you suspect whether you'll have early type 2 diabetes mellitus. In that case, HbA1c, if it is 6.7, you know that it is probably early type 2 diabetes mellitus, or if it is going to be 6.3, then you know that he is in the pre-diabetic stage with a postprandial excursion. Certainly metformin or alpha-glucosidase inhibitor. Metformin is much more rational for the simple reason it addresses the insulin resistance, and it is also recommended in the pre-diabetic stage.
Some of the diabetic patients having a systolic pressure at about 140 and having the diastolic pressure 100, 110. How do you manage with controlling keeping that systolic in 140 and maintaining the, to maintain the diastolic around about 90?
I think, as I've understood your question is, it's a beautiful question. When the systolic BP target has been reached, the diastolic is high, you're going to introduce a second or a third agent. This not only brings down your diastolic, but also the systolic. That's the question, no? Yes. See, the guideline says, do not target your systolic to less than 140. But if your patient tolerates a systolic of 120 or 110 without side effects, don't have to worry about it. You don't have to push it up to 140. So in the example that you have quoted, your introduction of maybe an amlodipine or a cilnidipine, which will bring down the diastolic to less than 90 or 80, will bring down the systolic as well. You don't have to worry about it as long as it is asymptomatic. So the guidelines never say that you should not push, they say that you shouldn't target it. But in the process of addressing your diastolic, if your systolic comes to less than 140, well and good. You never target. Like your HbA1c. For example, you have so many of our diabetic patients who are on DPP-4 inhibitors with metformin, HbA1c of 5.3. Will you ever imagine, will you ever push your patient to HbA1c of 5.3? No. But if it is going to be handy to you, without the risk of hypoglycemia, accept it. One patient, can we use or mix different guidelines? Why not? The patient is yours, the molecules are there. The guidelines is only an indicator as to how you go about. Whether it's a monotherapy or a dual therapy, when do you introduce insulin, when do you introduce a third agent, how effective or safe is a molecule, and how economical it is, plus based on your experience. I know a lot of physicians who have been very good practitioners of diabetology who still prescribe only glipizide. Most of us, I think in this audience, are probably, I prescribe a lot of glimepiride, I do prescribe, but you cannot ridicule those practitioners or physicians for prescribing glipizide, because in his experience, 20 years, 25 years, he says this is a time-tested sulfonylurea. Your glimepiride came in 98, whereas glipizide was there longer time, or glibenclamide. So all these have to be combined with your own experience of the molecule, and these guidelines are just to lead you how do you deal with your patients. Yes, why AGA is not included in the ADA? I told you the reason. No? So the primary diet of the European or the Caucasian population is more of protein-oriented diet. So the carbohydrate load is not there. That is why two things. Postprandial hyperglycemia has always been highlighted in the Asian context. And all the alpha-glucosidase inhibitors, be it acarbose or oglibose, the studies are only from Japan and some studies from India, China, and other Asian countries, Eastern countries.
In pre-diabetes, any guidelines for drugs?
Yes, in the pre-diabetic stage, more than the guideline, it is a soft statement made by the ADA that along with your lifestyle modification, molecules which have been tested in the pre-diabetic population like metformin, which has been tried in the various diabetes prevention trials, and alpha-glucosidase inhibitors, acarbose has been tried in the stop NADDM trial, can be used. So there is a passive, permissive clearance to the usage of these molecules, but they never said you should. For example, if the algorithm says lifestyle and metformin should be used in all diabetic subjects on the day of diagnosis, likewise it should be used. It is your discretion, and taking the clinical input and the utility of this molecule and its protection from pushing the patient to hypoglycemia, I think metformin can be tried in most of the subjects of pre-diabetes, starting with a small dose. What is the criteria to start insulin in first diagnosis of diabetes mellitus? A patient comes to you with a HbA1c of 9.2, last about 8 kgs, episodes of balanitis or vulvovaginitis or urinary tract infection. He will be an ideal candidate to start on insulin therapy because he is glucotoxic, he is symptomatic. Bring down the blood sugar level, and the dose and all is very, very arbitrary. You can start with 0.5 units or 6 units of kilogram body weight and then up to titrate the dose, whatever you want to do, pre-mixed insulin or a basal bolus. If in an outpatient setting, a patient who has been with you for a longer time, if this patient has been on 2 drugs, and if the deficit in the HbA1c is more than 1 or 1.5, why I keep on telling about HbA1c is the guidelines say that, because the guideline never says if your fasting is 160 or 180, no. You can extrapolate from your experience. For example, if the fasting is going to be in the vicinity of 200, 180 or 200, if a patient is already on 2 drugs, a third drug will not normalize the fasting blood sugar level or your HbA1c. On the other hand, if you fast, this is only a clinical discretion, your experience, because the guideline never harps on all these parameters. These parameters are the ones that you and I do it day to day to treat our patients. The HbA1c has been standardized, but we know when a patient has got a HbA1c of 8.8, you know the fasting is around 180 or 200 and the PP is around 280 or 300. So in such a scenario, there is no point in introducing a third drug. On the other hand, if a patient is on 2 drugs, if the HbA1c is say around 7.8, fasting is 140 or 150, PP is 230 or 240, he will be an ideal candidate for a third drug. Present role of glitazones. I wish I had not seen this question. Present role of glitazones. Maybe briefly, till how long you can. Another 5 minutes we'll take questions, because I'm not. I think when the glitazones were introduced, some of us, and you won't believe, I really spent a lot of literature because I was personally impressed with the glitazones. In fact, in all our journal club meetings, we used to talk about the mechanism of action of glitazones, even though it was not relevant, because I used to enjoy discussing about the glitazones. You know how they act? Beautiful. They convert the adipose tissue they proliferate the adipose tissue mass so that the free fatty acids in the circulation are trapped by the adipose tissue, and it's the beautiful way of ameliorating insulin resistance. That's what we saw in the clinical practice, whether it is rosiglitazone or pioglitazone. Even when the controversy with rosiglitazone was there, some of us, I have not believed the controversy. Even today, I do not believe that, but that is my personal perception. But the molecule was abandoned because of the association studies with the cardiovascular endpoints. With respect to the pioglitazone, all of us were using pioglitazone and patronizing pioglitazone till about 2010 or 11 when this controversy arose. Now, this controversy assumed a lot of significance because the signals emanated right from the proactive study in 90s. See, when the proactive study came, even then the Bladder Cancer Association was there, it was not statistically significant. But subsequently, they found out that one another case which was in the other arm, since this thing became benign, the originally insignificant association became significant. So you introduce a molecule in the 90s, right from that time, if the association with the malignant endpoint is not there, not yet proven, you as clinicians have to be cautious. With that approach, I have abandoned the use of pioglitazone in the last 3 years of my practice. That is my personal perception. A lot of my very close friends, in fact, we always used to argue, close friends and my own senior colleagues and contemporaries and students have been using pioglitazone. But having said that, if there are no external mics, I can say a very, very sincere statement. It was extremely unfortunate that this molecule was banned. It was a very, very knee-jerk reaction. Having done that, to withdraw that ban was equally immature decision. See, on the first hand, what happened was, when the government bans a molecule, the patients perceive that their practitioners have given them a molecule which is banned by the government. How can my doctor do it? The credibility of the physician takes a stampede. So many doctors told me, "What, sir, you should have told us not to use this. My patient is talking to me like this as if I've given a poison to him." So it is not the fault of the physician or the patient. It is the immatureness which is the issue was handled, in my opinion. And secondly, having done it, I always believe in this Tirukural. That is, before taking a decision, think about it. After that, whether it's a right or wrong decision, with the inputs you have taken a decision, I think with respect to the pioglitazone on both the instances, it is found wanting. Having said that, if you ask me what should you do under the circumstance, my position is very clear. I have not used pioglitazone. If you have been using pioglitazone to your patients, after the ban, if your patients feel that you have given a molecule, now to restore the faith, your faith in that patient, which is justifiable, because as on date it has not been proven, restart the pioglitazone in those patients in whom you have started. If the patient is young, if the pioglitazone exposure has been less than 1 year, 2 years, etc. If the patient has been older enough, the pioglitazone exposure has been longer duration, given this opportunity, withdraw them from the molecule, and new prescriptions, think twice before initiating. I think this will be my approach to the pioglitazone, taking into consideration everything. That is our position as clinicians who matter to the patients with respect to credibility, our own standing. See, we are not fools to have prescribed a molecule which is banned by the government. So the government has banned it because of various reasons. So that is my perception. A 58-year-old female came for mast-cell checkup, no complaints. Pardon me? For that matter, I have not come across a patient who has sustained a myocardial infarction in rosiglitazone also. So, having said that, whenever, as I told you, the pioglitazone problem is right from the proactive trial. See, the proactive trial was in the 90s. There was significant association. See, all of us know that glitazones have got a protective effect in malignancies. In fact, most of the trials, some of the softer endpoints have been the protection with respect to the malignancy, be it rosiglitazone or pioglitazone, along with metformin. These are the only two classes of molecules which have been protection against malignancy or a favorable effect. Whether it is insulin or OHA, sulfonylureas or secretagogues, probably it is not the case. Having said that, if a signal is going to be there associating with increased risk of a particular entity, then it is better to be cautious. Maybe the future, maybe 6 months, 1 year, 2 years down the line, you will get some more concrete information, like what you had for Lantus, Glargine. See, initially when the controversy came, Glargine was associated with cancer. But fortunately, I think Aventis, Sanofi Aventis, took all steps to see to it that that doubt was cleared. They spent so much and then had a lot of data to prove that glargine is safe as on date. I think to that extent, the people who have been marketing pioglitazone have not been enthusiastic to prove the medical world that this molecule is clean. I do not know whether it was not worth investing or whatever it is, I do not know. They have not done. So in future, if they go about clearing all the doubts, till such time it's better to be cautious. It's a question of perception and individual discretion. If you go by hard science, there is no concrete evidence to say. Yeah, this is about a lady, no abnormalities in blood sugar, RFT, LFT, urine analysis, but HDL was 90 in the presence. Please comment on high HDL. What is the specific advice? There is an entity of increased HDL based on some genetic defects or genetic advantages. If a HDL level is much more than, then it could also possibly theoretically, after all it is cholesterol. So when we talk about the HDL cholesterol the HDL is scavenging wherever free cholesterol is there, threatening to get deposited in the vascular wall, all in the cells. The HDL cholesterol collects it and then sends it to the liver. That is the basic mechanism of HDL. So when you have a good concentration of HDL, then you are happy that it is going to do more of a scavenging effect. But this HDL cholesterol, if it is long and sustained enough and going to survive in the circulation for a longer time, it could be detrimental also. But as on date, there is no medicine to talk about reducing the HDL cholesterol to the best of my knowledge, for the simple reason that be cognizant of the fact that beyond HDL, which is quoted in this as about 90 mg/%, maybe in the presence of a total cholesterol of 180 or 190, 90 HDL is high only, but it may be abnormal in situations, but I don't think there is anything to say that this has to be treated, and if so, with what molecules. To the best of my knowledge, I do not know.
The question be asked, sir, about alcohol.
To add alcohol.
Alcohol can be, HDL can be.
No. Question, you are asking whether alcohol. See, alcohol has always been found to be associated with increased HDL. But the subfraction of HDL, which is associated with the consumption of alcohol, has not been found to be beneficial from the point of view of atherosclerosis. Number one, the entity of HDL cholesterol itself is nowadays taking a backseat, especially after the laropipant and niacin. Yes, with this you are able to increase the HDL cholesterol, but it didn't get translated into the vascular benefits. So even though the association of low HDL with vascular events are there, improving the HDL has not been aggressively taken as robust evidence to indicate evidence of vascular protection. That is number one. And number two, with respect to alcohol, HDL2 and HDL3, the subfraction of the HDL which increases with alcohol has not been found to be vascular protective, even though in number it may be more. Because it stands to reason, once you take alcohol, everything goes up, including your triglyceride and everything goes up. Certainly this fraction of HDL is able to tap much more cholesterol, its number goes up, but whether it gets translated into vascular benefits is not known. Maybe we'll take one more question or wind up.
Management of such patients. Renal failure not related to diabetes, on immunosuppressive drugs, became a diabetic later on. The patient was on treatment. Now, because of the renal failure, your HbA1c becomes unreliable in order to know what the target is, and you need to manage them. So how do you go about that?
Yeah, it's a good question. I think all of us have this doubt in the day-to-day practice. For me, I believe in the city of Madras, about 5 or 6 institutions, the HbA1c is really, you can take it with the face in the sense that it's good. Of course, the 3 or 4 diabetic leading centers and Apollo Hospital wherein I have my main practice. Because whenever we give an input, immediately the standardization is tested and the accreditation lab is sounded, everything, etc. In other situations, you have to extrapolate. As I told you, it's just your clinical discretion. In the example that I told, see, when your HbA1c is 8.8, I gave a numerical example, the fasting could be around 200 and PP could be in the vicinity of 300. This is just out of I mean, clinical expectation, going by your experience and the knowledge, that's all. You can be wrong in these situations. So, as you rightly asked, it is very difficult to rely upon HbA1c, especially in labs which do not have that accreditation, number one. Number two, all patients do not have affordable to do the HbA1c, nor they are motivated. So in the absence of these two, you base your clinical decision based upon the fasting and the PP. So if the deficit in the fasting is to the tune of about, say, about 20 or 30 or 40 milligrams, I assume a third molecule will do the job. Beyond that, it's my assumption that it will not, and then you have to go in for insulin. I mean, it's very, very arbitrary. It's not that scientific, but experience-based, not evidence-based.
The unreliability of HbA1c is in renal failure. The carbamylation of a lot of things happen in renal failure. So the question is glycosylation in HbA1c. Yeah. The non-enzymatic glycosylation takes place in renal failure per se, not necessarily in diabetes. So that was the key.
Yeah.
So
that's a good question, but I thought in the day-to-day practice, in the context of a patient with renal failure, I don't think you need to bother much about the HbA1c. If he is fasting around 140, 150, PP is around 200 to 240, I'm happy, because my intention is to prevent an hypoglycemia in this. That takes priority, and then see to it that he doesn't go in for any hyperglycemic emergencies. With this being the objective, very loose control, HbA1c more than 8 or 8.5, or even non-estimation of HbA1c may be warranted in those situations.
So it was an excellent interaction, sir. Thank you very much for that.
Can I have just one final question? Because, I mean, I'm basically a nephrologist. Whenever I find difficult to diabetes, I always dumped on Mohan or one of these people. So basically, the question which I want to ask is, what do you do in your practice when you start to give, okay, let's arrest the beta cell, so let's initiate insulin early. How do you convince your patients about taking insulin?
So I think now the practice that we do in diabetology is talking about early positioning of insulin. We are not talking about giving rest to the beta cells. If you're going to give rest to the beta cells, then you have to talk about insulin therapy at the time of diagnosis. There are very, very few data are available. Such of those data is very impressive. That is, at diagnosis, start on insulin. See, a patient comes to you with HbA1c of 8.6 or something. Fasting is 202, PP is 330. Start him on metformin with basal insulin. Give for 1 month, 2 months. Then abandon that insulin, withdraw that insulin, introduce OHA. This is very, very early insulin. This is what I think you have been nicely harping about. That is, you are going to give rest to the beta cells. The patient have presented with diabetes. You give rest to the beta cells, give insulin. So this is a concept which is there only as a concept. It's very difficult to translate it into practice because many of us do not seriously subscribe to that theory, even though we talk about in meetings. On the other hand, what we do is early positioning of insulin, which probably in hindsight might be protective to the beta cells. For example, the examples which I frequently quote, HbA1c of 8.8, somebody is on submaximal dose of glimepiride, introduce insulin. In this patient, if you're going to introduce a gliptin, or some other molecule, a pioglitazone, it will bring down the blood sugar level, but it will seldom normalize it. So instead of introducing insulin on, say, 18th of August 2013, you might do it in September 2014, and this 1 year valuable time will be lost for you to give an opportunity to institute glycemic control. So as on date, it's not the early insulin therapy, it's the early positioning of insulin in the natural history of type 2 diabetes mellitus. Really early insulin therapy is probably a diagnosis. Maybe the future will give some good answers based on large scale studies.
It has shown some beta cell preservation also in the last October